And what characterizes a lot of what we're doing in the communities on the uranium legacy is about a whole history of chronic exposure. And these two photos from the same community near Church Rock, northeast of Gallup, it's the same family separated by 34 years and 3 generations. And they've been captive to their exposures to the mine wastes that are in the background here and the background there. From a cultural perspective, this family has been there raising sheep since the 1920s. Many of the people's umbilical cords are buried in and around the community. So from the perspective of being able to move away from the contamination, move away from risk, move away from exposure, it's not possible. And this is repeated throughout many indigenous communities, especially on the Navajo Nation, the Dannette Nation. In terms of our community engagement, this has always been a hallmark of all the things that we've ever done. The communities that are affected, they largely set the agenda because they're the ones that have to live with these long-term risks. All the exposure pathways in the environment through their various pathways, either from the contaminants getting into the water and people drinking water, contaminants getting into forage that the goats and the sheep and the cattle eat. And then what happens when the contaminants get into your body? What are the routes of exposure? And we've adopted something of an additional route in the birth cohort study that we've been working on because of the notion of the transfer of contaminants across the placenta from the mother to the unborn baby. We conducted the DiNEH Project between 2001 and 2011. It came out of concerns amongst people in the Crown Point area and the Eastern Agency for the potential for drinking and ingesting uranium from unregulated water sources. They were concerned also about the prospective reports of new in situ leach uranium mining that was proposed for the area that would have been done in the community's sole source of drinking water. And so there was a lot of concern centered around the fact that the kidney disease rates, chronic kidney disease, was very high in the area around Crown Point. We were able to, through a statistical analysis conducted by Dr. Lauren Hun and was published in early 2015, observe that during the so-called active mining era, those exposures to both workers and the families increased the risk of kidney disease. One of the largest single categories of self-reported exposures were amongst women who washed the clothes of their worker husbands, family members, from people who worked in the mines, lived in the mining camps, contributed to reclamation. We found these significant associations, and it should be noted about 10% of our study population were actually uranium miners. But by this time, in the early 2000s, first decade of the 2000s, so many of the miners had already passed away. As communities go, there are both population exposures, and every community has people who have also worked in these facilities. There was a relationship between how close you lived to the mine waste and how frequently you came in contact with the mine waste that increased your risk of hypertension and autoimmune disease. And interestingly enough, and this goes back to the notion of this record of chronic exposure, the median length of residence of our study participants was 33 years in their homes. So they were not a transient population. They were an older population. I think the median age was around 51, 52 years old. The DiNEH Project helped to inform both the design and the implementation of the Navajo Birth Cohort Study. For many years, the communities have been asking for health studies. in the aftermath of the so-called Waxman hearings in Congress on the Navajo uranium legacy in 2007, the government, through the Centers for Disease Control and Prevention and the HESDR, Agency for Toxic Substances and Disease Registry, came to Navajo, met with a lot of folks in communities, and came up with the idea of conducting a birth cohort study to look at uranium waste exposures and reproductive and child developmental outcomes. This is a map that was prepared by one of our postdocs at Johnny's office, Dr. Joe Hoover, that shows the number of people that have been enrolled in the study. This was through into October of last year, but you get the impression of where most of the people have been enrolled in the study, out in the Tuba City area and here in the Chinle area, and to some extent down in the Gallup area. The hatched areas are the notorious mining districts. Since this is a cross-sectional study, we don't turn people away who want to be involved in it. We had about 7% of the homes were in the mining areas. So we're looking at exposures that go across the board and not just in the impacted areas. Our outcomes model, and it's kind of full with redundancy because we understand that there's not one measure that is always foolproof or always associated with the exposure. We need multiple measurements. So we have a variety of exposure inputs for uranium through the biomonitoring data. You'll see some of the soil data that was collected by the government for the national uranium evaluation. We've done home environmental scans, or radiation scans for gamma radiation. And then these are all the effect modifiers that then go into our analysis of reproductive outcomes and child development outcomes. We have an elaborate exposure survey. It's about 115 questions from the mothers, about 75 questions for the fathers. We're looking at occupational histories, time and activity patterns, family history of exposures, pregnancy questions. We're conducting these home environmental assessments that I'll show the results of next. And then the biomonitoring, where we're looking at 36 different metals in blood and urine, along with some of the classic metals, lead, cadmium, and total mercury in whole blood, and copper, selenium, and zinc in serum. These are the collection points for the mother, the father, and the baby. For blood, urine, and meconium, we're collecting meconium for alcohol metabolite analyses, amongst other things. The importance of the home environmental assessments is that it gives us exposure data where the people live. We don't find much excess gamma radiation. We've only had about 6.5% hit on indoor radon, but these are the big two here. Almost 9 out of every 10 homes have measurable levels of uranium in the dust above the detection limits, and almost 61% have metals in dust that exceed screening values to account for the chronic exposures or repeated exposures in homes for where people live. Drinking water is also a major concern for exposure, since about 30% of the population lacks access to regulated drinking water, and in our study it's about 19%. So we have a population that is more connected, so to speak, to public drinking water supplies. Through an analysis that we've all been working on with Dr. Hoover, myself, and others over the last many years, we now have consolidated water quality data for more than 500 unregulated water sources, and we're seeing exceedances of the arsenic MCL in about 15% of those, and the uranium MCL in 13%. The MCL is the maximum contaminant level that is set by the government, EPA, and in this case also the Navajo Nation, but not all public drinking water supplies are in compliance. About 11% of our participants have been at one time during their pregnancy drinking water from non-compliant PWSs. And this shows you the distribution of arsenic above the drinking water standard and uranium above the drinking water standard. You have hot spots over in the Eastern Agency where a lot of the old mining took place. A lot of contamination down the central spine of Navajo. So we're looking at both anthropogenic and natural causation. Of course, uranium, arsenic, they're all natural. It's just what we humans do to them to increase their concentrations in the environment. Another one of our major efforts to define exposures through the biomonitoring of the blood and urine samples that our participants give at various stages, beginning in the prenatal stage at the enrollment survey, at delivery, both for mom and for the baby, and then at different stages for the baby during their first year of life. And we have found that more than a quarter of the study participants have urine uranium concentrations greater than the 95th percentile of the NHANES national average. So that's 1 in 20 adults in the United States with these kinds of concentrations, and we've got 1 in 4 in our population. So this reflects a significant finding of kind of ongoing exposure. It's especially important for the mothers at enrollment and on delivery and the fathers, but you'll notice that one of the numbers is down here. You'll notice that the urine uranium for the babies increases with time during their first 12 months. Many of the drinking water supplies, many of the unregulated water sources are not at the same level of exceedance of this 95th percentile. This is not a standard, it's just a means of comparison. However, we're seeing in other places and other studies that arsenic even below this level may still be harmful over time. We don't see blood lead at a high concentration in the mothers, the fathers, and the infants, even though it's the most frequently occurring contaminant, metal contaminant in the dust in the homes.